I'm sorry, I'm not hearing anything now.
This turns on.
Oh,
Let's switch.
I think the microphone's just not working. There you go. Okay, is that better? Whoa, there we go. Hey, that makes a difference.
There you go.
That makes a difference. Okay, apologies, the microphone was not working. All right, so we did a call for citizen input, and there is nobody here for citizen input, so we will move along to board reports. And just a reminder that the agenda packets are in the binders, and the agenda packets can obviously be taken home, but leave the tabs and the manuals here. And then just a reminder for everybody, only 6 microphones can be on at a time, and please turn them off when not speaking. Okay, Commissioner Waldriff, do you have a chair's report? Commissioner Waldriff, do you have a chair report?
Yes, sorry, my connection isn't great. Can you guys hear me?
We got you.
Okay. Well, I just wanted to let everybody know that I am finishing up my time in Washington, D.C. And I was here with a group of Board of Health members from across the United States. And we also met with officials, public health officials from across the United States as well. And we joined them for a lobby day on the Hill. And it was very interesting, just learning about all the different types of funding that come down to the health district from the federal level. So I appreciate Kim and Dr. Thompson being available to answer questions and provide a lot of detail. So I could provide that detail to Representative Baumgartner, Senator Murray, and Senator Cantwell. So we were able to meet with all 3 of our Congress people and talk through some of the important federal funding that comes down to the health district. So it was a real fruitful week. I'm concerned about potential Medicaid cuts and potential other cuts to the CDC, where we rely on a lot of their data for the work we do here. So more to come, but that's a little update from me from my trip.
Very good, thanks so much. Is there a report from the executive committee? Commissioner Kearns, anything on that to report?
The executive committee, mainly we just went over the agenda that we're going over today, and I think that was essentially the gist of the meeting, as I recall.
Very good. And then is there a report from Budget and Finance? Did they meet? Does anybody know? I'm not on that. Not seeing anybody. Commissioner?
I can
Yeah.
give a quick update. We went through the vouchers, and Commissioner Cuney and I, and sorry, I can't see, when the camera's on me, I can't see everybody else in the room, but we went through the vouchers that we can vote on today. We went through any of the financial documents. We discussed a few financial issues, but all is looking good. We got our latest dollars from the state, and so I'm sure Kim will give us more updates there.
Perfect. Okay. And there was not a meeting of the Policy and Education Committee, so we can move on to our consent agenda. Is there a motion to approve the meeting minutes from January 30, 2025?
I'll move to approve the consent agenda.
Okay, and is there a second?
Second.
All right, motion and a second. Any discussion? Hearing none. All in favor, say aye.
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 And any opposed? Okay, motion carries. Okay, Michelle, if you'd like to stipulate why we're entering executive session?
Happy to, thank you. So first, I want to announce that although labor negotiation guidance was identified as a reason for executive session today due to Dr. Thompson's inability to be here and Labor Council's inability to be here, we're going to move that topic. So executive session will be solely litigation, potential litigation pursuant to RCW 4230-110-1I. I anticipate 15 minutes, and I think we just need council and the board. Don't know, is Alicia going to participate or not? She's not, okay. And Danielle, I don't think we need you for any of those today. So that'll be it.
Perfect. So if everybody else can clear the room. So we can move on to our action item here, the resolution adopting the 2025 to 2030 Spokane Regional Health District Strategic Plan. Is there any presentation or anything that goes along with this? No? Okay. Well, is there a motion then to move this resolution forward?
So moved.
Second.
All right, motion and a second. Any discussion related to the strategic plan or this motion? Seeing and hearing none, all in favor of the motion, say aye.
Oh, I just had a quick comment.
Oh,
Sorry.
I can't even see that hand. Thank you, Commissioner. Go ahead.
No, I just wanted to thank all of the, Patricia and I, thank Patricia for giving a lot of her time to the process. And then all of the staff and the community partners that participated in surveys or sat on the committee. There was a really good process, and the strategic planning consultants were really great. I just think this plan is really practical. It's really easy to read. It has 4 main goal areas, and it says, here's what we're going to do over the next, is it 3 years? Is it 3 years or 5 years to achieve the goals? And so I'm happy. It's easy to read. I think the community can really, and the staff at the health district, it's really a manageable and practical and achievable set of strategies and goals. So congratulations to everybody who worked on it.
Okay, thank you for that. Any other comments? Okay, well, we've got a motion and a second. All in favor, say aye.
I
Aye.
Aye.
Any opposed? Abstaining? Okay, that motion carries. All right, we'll move on to our reports, and our administrative officer, Dr. Thompson's not here. She's out due to illness, but we do have a treatment services update.
Thank you. Is this thing on? All right. Okay, so I am going to do my best walking through this update, recognizing that the information is being supported by Adam. Whoops. Is it on, or am I just too short? There we go. So Adam's going to back me up in some of the operational information, and then if there are questions in regard to the financial portions of that, I believe that Kim will be covering some of that in her financial update afterwards. Okay. So let's go to. So first, we're going to be looking at the January 2025 expense and revenue for treatment services. You'll note that overall, the expenditures so far as it just at 6.4%. The first line there for expenses includes the salaries, benefits, supplies, capital equipment, and so forth. There haven't been any major supply purchases for January. And then funding comes from Medicaid, Medicare, fees for private pay insurance, indirect, federal, and some other grants that we have, as well as employee parking and donations. For January, there is a surplus currently of 984, excuse me. So this graph shows patient count by program, excuse me. The dark blue is the OTP, and of course the green is then the courtesy dosing. Courtesy dosing meaning that they're not a standard client. Isn't that correct? Yes. Okay. And so the next slide is really looking at the comparison of total patients turned away. You'll notice that the grand total in 2024 is 205. At the time, or during the year, it was the majority of them were turned away from no available spot for services. So far in 2025, we've turned away 4 individuals, and the reason for turn away is that they had no proper identification. January 2025 services provided includes individual counseling, telehealth, group counseling, annual physicals, dose evaluations, and so forth. If you note that the individual counseling, the telehealth counseling, and the group counseling sessions look a little thin compared to the overall client number, what you should recognize is that the standard client number for revolving clients coming in and out is about 955 per week on average, and so that reflects that more clearly here, that they are truly getting services. We don't see the fall off or the clients coming in. And then total services provided, so 968 clients dispense medication in total. So goes back to those previous two slides and how we were talking about other resources being provided.
This is strictly OTP.
Ah, this is strictly OTP. Sorry, you want to speak to this a little bit? Okay. Any questions so far for myself or Adam?
It's not really a question, but Amber and I were discussing that we'd like these reports to be in our board packet in the future.
Any issue with that?
No.
Cool.
No problem. So January 2025 services provided continued. We have 53.3 clients that actually checked in for their appointment status, and 25% as no-show. And there's a range of reasons why they wouldn't have come in, which is cancellation by provider, pending, canceled by patients, or rescheduled. And then courtesy dosing encounters, there's 274. Does everybody understand the term courtesy dosing? Okay. Some of this stuff is somewhat newer to me. And then 55 unique clients dispensed medication total. For January 2025 jail encounters, there was 698 total jail doses delivered to 36 unique patients. This is actually a significant number considering that 2024 total was 5,593 with 145 unique patients. Any questions on this treatment services?
On the last slide, I assume some of the folks treated in January of this year are the same that have been treated in the prior year.
Yes.
Okay.
Yep.
Yep.
Any other questions from anybody on this? Not seeing any hands? Okay. Thank you so very much. Okay, let's kick it over.
Sorry,
Yeah.
Councilmember
go ahead.
Cathcart. So just to clarify, so those were those the data points that the board identified that we wanted to see at last month's board meeting? Is that what these were generated from?
I'm not sure what all was requested. I know I had asked for the kind of unique versus the group, and I think this kind of gets to that, but were there other requests?
Well, I just remember there was like 3 or 4 board members that asked wanting some different data points, and I was just hoping we captured that, and maybe we just need to go back to the notes from January to make sure, but these seem like they mostly covered what we wanted. I know we wanted to know how many people weren't coming to appointments. We wanted to know kind of the difference between the different populations. And I think we requested the jail info as well, but I just wanted to close the circle, make sure we got everything that we needed, so.
So this one was requested at last month's meeting to know in 2024 how many courtesy dosing were unique and how many in OTP were unique. So this number is 1643 versus you guys were shown 1602, which also speaks to the fact that some of those courtesy dosers then come on to our program at OTP, which is why that unique number is lower.
Very good. Okay, that's interesting.
I
Patricia?
have one sort of comment. Just for the next update that we get, I'd like a little bit of a discussion about the way that treatment services is approaching abstinence issues, especially with pregnant mothers. I think and I wish I had my notes with me, but I don't, so if you want to circle back to me about it, but one of the qualifications that was sent out to us. One of the legal language has to do with abstinence and with whether or not treatment services is promoting abstinence or not. So I just would like to hear a little bit more about their approach to that, how they see it, their philosophy kind of around that, and what they're actively doing to, participate in that as a goal for people who use the service. Okay.
I just had a question. Yeah, on that note, are pregnant moms eligible to be part of the program?
Oh,
Great, okay,
yep.
thank you.
Okay, nope, I think that'd be some good input to get. Anything else that we'd like to see for the next report? Commissioner?
I guess I just have a question about the 25% no-show. Is that kind of standard across the country? When you see 25, to me, that seems like a high number. Do you guys view that as high, or is that sort of standard, kind of par for the course?
That's not only standard for us, it's basically standard in like the industry.
Okay,
Like
so
that's-
okay.
Because I've been doing these exact same numbers for years on end now, and it's stayed basically flat.
Okay,
It's always about that.
okay, thank you.
Say for regular service clinics where you're going to see your doctor provider, that would be an extremely high number, but that is it's not high here.
Is there anything that can be discerned from the population who do no-show? Are they more likely to relapse or, various things like that, or?
I think it's just more of the same thing that Misty talked about last time, transportation issues, childcare
Okay.
issues that interfere with the set appointments.
Would it be helpful for this board to see a breakout on that percentage for each of the areas that they're representing for canceled by provider, pending, canceled by patient, or rescheduled, so that we would have a better understanding about how that 25 is derived?
Was that the remaining, the other 25 or so percent that's not
No,
calculated there?
that's the remaining, yeah.
Those two are the top categories. Everything else is a pretty minor.
Yeah.
Like,
Oh, so
No,
those reasons below, the cancellation by provider, that's in the 25%?
No.
No, that's
aside
what's
from, yeah.
outside of the 53.
that's the other 22%.
Okay, that's what I thought. That's what I thought. So
I just didn't know if it would, because we have the two numbers here. We don't have 100% that we're showing you. I just didn't know
Oh.
if having that other detail would be helpful at all.
So the no-shows here are folks that we don't have a reason, an official sort of reason for cancellation or not showing up?
They just don't show up.
Yeah. Do we do any survey work, anonymous survey work even, to gauge those more accurately?
We just sent out our Voice of the Customer survey, which April here led.
Yes, so we did just wrap up our Voice of the Customer survey for 2024. We do it annually. I do have a share out of that we could provide at the next
Okay.
meeting.
That'd be great, yeah. We can have more discussion then. All right, anything else on this? Not seeing.
Just one
any?
more thing, just
Yeah.
if we can make sure that we're tracking the things that we ask to be provided for the next meeting
Yep.
and presentation, and, following through with that so that they don't get lost.
Somebody's tracking that, I'm sure
Yes.
it'll be in our minutes too, so, very good. Okay, if there's nothing else, all right. Thank you guys very much.
Thank you.
Okay, we'll jump over to our financial report. Take a look at the money.
And I believe I do have one slide. Good afternoon, everyone. Were you just using the mouse, or did I need to advance?
You can advance right here. With this one.
Okay, perfect. Okay. So this month's financial report is in your packet, but since it is the month of January, it could fit up on a slide a little easy, so I wanted to include that as well. We are working on 2024 and closing out the book, so I do want to mention that, and you will see a report hopefully next month, I can show you our final numbers for 2024. So this month I want to emphasize where we're at for 2025 and where we're starting. So of course, we're on a calendar year basis. Our total agency budget is 57 million. Our expenses are broken into a few categories. Salaries and benefits are a significant portion of the overall $57 million budget. You'll see 22 million plus benefits of 8, so about 30, almost half of our budget is salaries and benefits. Then we also have supplies and then services, and we have quite a large line in the service category. We do have one program at the health district, the early support services for infants and toddlers, the ESIP program, where we have about 17 million that passes through. So that does show a large amount in the service category. And then also that is one of the reasons our state grant shows up at 20 million, is we have about 17.1 million of just that grant. So working down into the funding for the health district, we have pretty good diversification as far as different revenue streams. The federal indirect grants are 7.78 million, which is about, I have the percent here, 13.51% of our overall budget. Then the state grant is 20.4 million. And a point to note about the two grants, both state and federal, is that very, very few exceptions were expense reimbursement, which means the health district fronts all the money for the expenses, prepares the billing at the end of the month, and then submits for reimbursement. We usually get EFT payments from the different grantors, but there's about a 45-day delay minimum in getting reimbursed. So it's really critical that we have cash flow to front those dollars, and we stay on top of our billing. So that's a high priority in the finance department. We have an interlocal grant, 515,885, which is predominantly the TB contract with Spokane County, and then we have a JOYA contract for some Medicaid administrative match. So those are both through Spokane County. Medicare and Medicaid, Lola presented on treatment services. It's very heavy for treatment services on the Medicaid, Medicare. We also have some Medicaid funding for our HIV STD program. The fees and permits category, very heavy on environmental public health and their fee-based programs. In addition, that would also be where we have insurance provider payments, would be under the fees and permits. And so we do bill insurance where applicable and where we have contracts for treatment services in those clients. The next large funding stream is the Foundational Public Health Services. You've probably heard that over the years. Funding for FPHS comes to the health district in 6-month increments. It's one of the unique funding streams that does advance the funds to the health district. So every January and July, we receive the FPHS funding. So for the month of January, we received approximately half of our allocation. Some of that, that is the 6-month allocation. We're working on carryover right now. So the grant actually runs July through June. So unspent dollars from July through December of 24, we can roll into January of 25 and monitor that grant period. So that's an advance payment meant to cover 6 months of expenses. And then our public health appropriations is the state of Washington. That used to be the motor vehicle excise tax funding from many years ago. This number has been the same, 2877318, for 15 plus years. Has not gone up, has not gone down. It also funds in advance to the health district. We receive the funds every January and July also. The January funds, though, that come in are announced through the legislature in November. So those dollars actually get coded back to 2024. So even though we received a cash payment in January, it's related to 2024's revenue. So it's in our cash account, which is great, but it's reflected in 2024's earnings. So you won't see a payment there until July. And then again in December for that category. And then, of course, Spokane County contributions. Thank you, commissioners. This is the allocation that's been dedicated for public health from Spokane County, and we receive those quarterly. So the county went through a new system, as you're probably aware, and so our payment normally would come that first month of the quarter, and we actually had the transfer, or actually a check this time in February. So we have received the first quarter funding, and you'll see that reflected in the next report, next month's report. Interest and earnings is strictly the Spokane County investment pool, and that's where our dollars are combined with the or with the county and then overnight investments. So with the increased interest rates, we've bumped up the budget to $425,000. We also have a surplus in that area for 2024 because of the increased rate that we didn't anticipate, and so we have some extra earnings there. Donations and foundations certainly change year to year, so it's hard to budget for that, but we did anticipate this 175. Some of those are funds that we are seeing as repeats that come in, and I'm currently analyzing the funds that have come in 2024, and if we haven't fully exhausted those dollars, they do roll forward into 2025. So you'll see that updated. Is there a question?
Yes, thanks, Kim. I was just curious about additional information on where specifically, what's examples of donations or foundation sources?
Sometimes, like our quality of life survey, for example, there would be other organizations that want to contribute towards that project, and we don't charge them a fee for that. They want to participate and contribute towards that project. So that's a good example, and we'll see that from some other entities. Then we also have had some private donations that have supported our NFP program. It also will capture things such as funding that just isn't state, isn't federal, and it might come through Better Health Together. It could come from like AmeriGroup, some other groups. They're non-federal, non-state. And so a lot of times they're considered a donation from a foundation as opposed to being a fee for service that we're providing.
Kim, the first two, the federal indirect and then the state grants.
Yes.
Is there something unique about January? Because that just seems so low. Or have we just not fully calculated out those numbers?
Yes, no, excellent question. The nature of those two grants is that we spend the money in the month of January. As soon as the month closes, then we prepare our billing and what we can reimburse. So those are being prepared now, and by the end of February, they'll be posted for the month of January. So it's that delay of recognizing that revenue.
Okay, so a month in arrears.
It's always in arrears on those.
Okay.
So what you'll see, and when I bring February's report forward, is that now I'll have significant numbers in the federal indirect grant and state for January, but February will look very, very small,
And
like
then
it does now.
Medicare, Medicaid, is that based on the clients specifically? Is that where that's coming from?
Yes, it's,
Okay.
and that is actually current. So it's all the medical bill, or all the Medicaid and Medicare billing, that's all the services performed in that month are then posted. And we also do accounts receivable posting to accrue anything that maybe is just the billing is out, but we haven't received the cash.
Okay.
Yeah,
Other questions?
great question. And I'm sorry, I usually bring that up about the timing of those two, because they always look very small. And then the next month, in February, you'll see January gets a bump up, and then February will be small in those categories.
Gotcha.
And then the last two items are, we have rents is just the category, and we're collecting for the garage parking and also the 8th Avenue parking lots. We do collect for the parking lot around this building, but those dollars get forwarded onto Spokane County as the owner of the lot. So there's a little bit of revenue there. It does help to cover the cost of our CTR program. And so being an employer of a certain dollar or certain employee count, we have to have a CTR program. And so that's a self-funded program. We do hold back some dollars to cover costs of the maintenance of the garage and parking lot. And then the last one, our budget for 2025 is we anticipated some projects that were going to happen that we had put into assigned reserves for facilities is one of the large ones. And so we're anticipating utilizing those dollars in 2025. So those are dollars already set aside in our reserves, and now we're anticipating using the $2 million.
Okay. Are there other questions from anybody? Go ahead.
So we've been hearing that there's some potential decrease anticipated through the state or for public health. Are we able to plan for if we see significant decrease in support through state funding sources or grants?
Yeah, absolutely. So far, we haven't been formally notified of any specific reductions, but we're well aware of the changes happening at the state, at the federal level, and we're in communication with DOH on regular calls. Just today, there was a governor's press conference at 11 this morning, and an area of interest was, for the health district, was foundational public health services was identified to have a reduction in the next budget cycle. Of course, it's proposed at this point,
Yeah.
but, and that would impact our $6 million that we have currently on our FPHS funding. It looked like about a 14% cut. What we don't know, if that comes to materialize, will that be across the board in every FPHS program? Because it does come in specific to specific activities. Some of it is more flexible with reinforcing capacity. So will those cuts be a specific FPHS project, or will it be just across the board? So we're watching that. That's really the first material thing we've seen. We do have an awareness, of course, that our federal indirect grants is heavily supported in our WIC program. So that's a large portion. We have an NFP program that's federally funded. Our emergency preparedness and response has some federal funds. So we're monitoring and have identified all of our projects that potentially could be impacted. And so we are, everyone's kind of waiting and watching. And so, of course, expenditures that are coming through, we're like, let's take a pause and take a look at what, the essential things we're doing. But so far, we haven't received any formal, and we expect them to be specific to programs and not across the board cuts. And that's just what we're waiting for.
Okay.
But yes, we have budget software that we could go back and, recompute the entire 2025 budget, and go through that process again.
Okay, thanks, Kim. I had another question just in terms of revenue opportunities. So is there any thought to potentially enhancing our revenue through our Medicaid program, through maybe expansion of the OTP program? And then similarly, do we have any thoughts or plans to potentially increasing funding through the donations, foundations, through partnerships and things like that, to kind of think about different opportunities to enhance our revenue since, other funding options may be in jeopardy?
Yes, great question. One thing I can share, I don't have the formal letter or the formal 2024 report. However, we are anticipating about a $2 million surplus from 2024 to go back into reserves. So that's a better position to be in than others, right? And there's a lot of factors for that. One I mentioned was the interest rate. We collected more interest. Treatment Services was running a surplus for 2024. So they're able to reimburse the general fund the $641,000 that they had a deficit the year prior. So they're going in the positive direction now. We also had funds set aside for separation. When we have employees that separate from the health district, we have payouts of vacation and sick if they're eligible, and those are not eligible for grants, to be billed against grants, so we have to use our local dollars for that. And so we over budgeted or overestimated, so we have some savings from that as well. Also, our Vital Records program brought in more revenue than it was to actually offer the program, and those fees are set by the state. So we do have some savings from 2024 that we're going to put into 2025. But as far as Treatment Services and increasing, I can't really speak to expansion of Medicaid as far as the other services, but certainly bringing in more clients. And if we're able to do that with not much more increase in staffing, and we still have the same facility and so forth, if our numbers would go up, certainly that would help bring in. And Treatment Services did run a surplus, so that can help the general fund as well. And then as far as donation foundations, it's a little bit of a slippery slope. We have to be very, very careful that we don't lobby, that we don't ask for funds. We certainly can accept funds if someone wants to contribute to a program, but we can't in any of our capacity in our roles to formally ask. Yeah, so if somebody does approach our programs, we can certainly give them the avenue on how to contribute, but we have to be really careful on how we approach that. But certainly when we do projects like quality of life survey, and it's benefiting many agencies, it's very appropriate to share that and share our costs and those contributions. And then some of those other funding streams are just other grant opportunities that they don't fall in state or federal, that we do watch for. And so that's how the foundations would come in, that a foundation may want to give a grant and it just doesn't fall in our state or federal grants category, but we can apply for those and certainly do outreach. And that's part of all of our program manager and division directors' roles, is to look for those opportunities on a regular basis. So absolutely. And
Commissioner-
that number has gone up and down over the years, for sure.
Commissioner Waldron, see your hands up.
Yes, Kim, when you sent that spreadsheet to me with the different federal funding sources detailed, you had a column that said Department of Health and Human Services. And that's the
The indirect federal,
pot of money. Right. Now, does that include CDC funding?
it does.
Because when I was in DC, the big conversation was about cutting CDC funding, and I'm thinking that's a large portion of what comes through Health and Human Services, correct?
Correct. So yes, what Commissioner Waldron is referring to is that we have a spreadsheet that we've put together on the details of the 7.78 million on indirect federal, as well as, of course, the Medicaid and Medicare, to just include those as potential impacts. We itemized or identified all the programs that are part of the 7.8 million. Department of Health and Human Services is our largest. It's about I don't have it in front of me, but a little over 3 million. And specifically, their CDC grants pass through Health and Human Services to us. And so CDC cuts, Health and Human Services cuts would be a big significant impact to the health district. Also, we have Department of Education is another component, which is with the ESIT program. And then the NFP program is part of that. And then the WIC, we have U.S. Department of Agriculture. So that's another one that we're watching, because that's over 3 million for our health district. So we're watching those individual agencies as well that make up the 7 million.
So I guess my question is, in the calls you've had with the state BOH, is there any conversation around actually increasing the amount from the state if there are federal requests that are conflicting with state law that we can't comply with, to ensure that there is no loss of funding?
So we do have Friday calls with the interim Secretary of State, and she shared that they've gone through their programs and have done the 6% cuts across the board that were asked at the federal level. They haven't disclosed a lot of information yet. They're sharing that it will be probably this week and part of next week that they'll be able to share more. But they haven't given us anything concrete about their ability to backfill maybe where those federal cuts would happen. They've indicated that they're looking at their programs at this point and not the pass-throughs down to the locals. So that's where they're starting with. But they don't know what will happen with the feds to their program. But right now they're looking more at their Department of Health making the cuts there and not at the pass-through to the locals.
Gotcha. Okay. Anything else on the, go ahead.
I have a
Yeah,
question.
Councilman Cathcart,
Go ahead.
This is just discussion about cutting the CDC's budget overall. I don't think it's, from what the conversation was in DC this week, it's not related to any program that your health district might be doing. They just may be cutting millions, if not more, dollars from the CDC, which could have other implications too for our knowledge of diseases throughout the U.S. and how to manage for measles outbreaks and other diseases that the CDC helps us with. So I can share more info after the meeting.
Yeah, no, that's great. I mean, and I don't have so it's great to get your input. I don't have a whole lot of time to focus on the federal stuff, but just the peripheral stuff I hear about is, there could be cuts, but then they might move them into other programs that are dependent upon various things, actions taken by various entities. And so just wanting to make sure that the state is going to step up if that's the case. So, or at least that those discussions are happening now, so,
Yes, definitely.
yeah, very
And
good.
then, so just to finalize the report, for the month of January, we're at positive surplus to the reserve balance, 1.3 million, primarily from the prepayment of the FPHS funds that will be used for the next 6 months. And then the lower portion of your financial report, which is not part of the screenshot, is our reserve balance. And because December is not closed and there's some numbers that will be moving, I wanted to show the snapshot at least of November 30th and where we would be based on this 1.3 million increase. So overall, we're at 18.8 million in reserves, still having the board emergency at 1.5 million. And some of these assigned reserves will change based on the analysis of what was utilized in '24. And I'd love to close the books a little faster if I could. Our auditors consider 90 days after year-end close as an active period, so it's kind of a delicate balance on what I can share, but I am anticipating right around the $2 million surplus for '24.
Very good. Anything else?
I have a question.
Shoot.
Kim, I'm still trying to get a grasp on the way that treatment services acts sort of independently in their finances. And I'm wondering if you can explain that a little bit to me. And also, are there any ways that where changes could be implemented? You know, we don't get reports from them, but we also don't get really reports from other departments. So I'm just trying to close those gaps or see how things can be a little bit clearer for us when we're trying to assess how things are done over there.
Sure, certainly. So of the budget of the 57 million that we have and that we prepared for 2025, I can speak to that we did not anticipate or we don't budget for any surplus coming out of treatment services. So this is showing a zero-based budget out of treatment services. So we have not had a history of utilizing or have an expectation of surplus coming out of treatment services to fund other programs in the health district. And that's really true of any program. When we do the budget preparation, we look at all known revenues that are coming in from the different revenue streams, fees, grants, and then we back in our expenses and see if we can live within the grant. And that's really critical, especially if it's a grant award, to balance those as close to zero as possible so that we're meeting the deliverable and the grant is paying for those to cover those costs. We run into some programs where we don't have full grant funding, or we've determined that they're supported in the community and the board has supported in the past. An example of that would be the data center. Data center is, as you know, is tremendous with their data and sharing in the community. They do work with some entities to have contracts for some of the work, but that work is usually specific to that entity's need. And so we've used some FPHS funding to help offset the cost of data center, and then also our local dollars has helped support that. And we bring that forward to the board to show where the county contribution comes into play and covers that, as well as the state public health appropriations that we receive. So we use those dollars to help there. We also use that to cover our communications department. So that's where some of our if we have grant opportunities, we do allow the team members in communications to charge to the grant and direct code, so we can capture if they're written into doing a campaign or any sort of communication project. But they're supported by local dollars. We also have the epidemiology program. They have gained some additional funding that we used to have some grants, and then we'd have to, and then some FPHS grants, and then we'd use local dollars. They're really closing that gap more and more. And I think this last year we were able to cover the entire program with grants and FPHS funding. So, but we don't take any one program and make an assumption they're going to bring money in. Like, for example, I mentioned vital records. The fee for the birth and death records is set by the state. So we work really hard to make sure our team can live within the funding that comes in. And of course, that's cyclical and, the amount of certificates issued. But we've been able to predominantly, I think we've always covered the costs. in that category. So to answer your question, if any program at the end of the year runs a surplus, regardless of it being a specific division like treatment services, or for example, vital records, we don't set those into specific reserves. We let that all go back into the general fund. It benefits the health district. And any program that maybe didn't expend everything, if they're local dollar funded and they had some either staffing changes where they didn't fill a position for a couple months and so they have some savings, that just goes back into the general fund. So those things happen naturally and throughout the year. And so with the treatment services discussion is they're Medicaid and Medicare funded. And so those are fees that are established, the established rate. We don't set those fees. And so as long as we provide the service with the fees that we're collecting, then we can run a surplus by definition. We can also go the other way. You know, we can't raise the fee if our costs are more. And so what we'd like to do is have a robust program and cover, and, you know, have it cover itself. But we haven't had a reliance where we take funds from another program and then give it out or separate it. The example with our assigned reserves that we have set aside is when we know there's a project for the health district that we want to set some money aside, like the roof, for example, or we need to do masonry work in 2025 for this building. The repairs and patches aren't sustaining us any longer. So we would, in dialogue with Budget Finance Committee, talk about, okay, we have a surplus in this year. Could we set aside some funds for assigned reserve, use those dollars, extra general fund dollars for that project? And that's what we do. The other portion of assigned reserves have been for environmental public health. And that is little different than treatment services because the fees we create, we establish our own fee. And so we have to look at, environmental health has to look at all their costs, what it takes to do inspections, the number of inspections they're going to have, and then back into that. And they also work with the food establishment committee to share, you know, how they're doing their fee establishment. But what happens is, because we set the fee, if we run a surplus and we overcharge essentially all the permits for the year, we don't put that back into the general fund. I mean, it goes into the general fund, but we have it assigned and separate, and we say, okay, the food program had a surplus in '24, so we're going to put those dollars aside, and then we're going to use those dollars to help offset 2025's budget. If we've overcollected over time, we've actually done a rebate where we've offset permit fees in the future to give that back. So that's where it differs a little bit with treatment services, because if we run a profit, there's no expectation that we have to track that and reimburse clients in the future. But certainly when we establish our own fees, we don't want to make a profit, we want to cover our costs. And so we monitor that really closely. And the flip side, we don't charge environmental public health. If they had to use reserves, then we cover that for them. But if they run a surplus, then the expectation is we'll have it separate. So as you can see, treatment services in their current model, they're bringing in, you know, quite a bit of money. January, 192,000. I'd be a little cautious on that just because January's expenses typically are paying December expenses. January activity is paying invoices from December. So when we see February, then we'll be able to see what are the January supplies and services that were related. So it may be a little bit high in that regard. But again, I don't know, does that answer your question? As far as how we use the reserves and.
Yeah, I guess I'm just more wondering about the way they have their internal finance department structured. And I know you've told me a little bit about how
Sure.
that works, but I just wanted to cement it in my mind a little bit
Yes.
better.
Yes, so treatment services is definitely part of the health district, is just like all of our other divisions. We do a cost allocation plan to calculate the indirect rate that we charge all programs to cover human resources, IT, general admin, HIPAA programs, contracts. We did make so everyone would pay the same rate in the past. When treatment services relocated to a new facility, it would not be appropriate for me to charge them the same rate as everyone located in this facility. And so they pay a different rate, lower than everyone else, because they're paying directly for the costs associated with that building at 8th Avenue. But we're capturing all the other costs. So the same HR team, same finance team is managing treatment services, or supporting, I should say, is a better word. But all direct facility costs are being paid by 8th Avenue and by treatment services. As far as management of some of those administrative positions at treatment services, we do have a medical billing, insurance billing department, and they actually are funded by treatment services, but managed by my team. They're part of finance of the health district. So that way we have the financial oversight of the entire agency. But the staff that are supporting and doing the medical billing are paid for and funded by treatment services. Same thing with facilities. We have Travis, who's the facilities manager of the health district, but we have Martin, who's funded by treatment services, and then all of his team of facility and security, they are funded by treatment services. But they're ultimately managed by the facilities manager of the health district. So we have some administrative oversight, if you will.
Yeah, that's what I was.
So we don't do,
wondering
yeah, we're not
about, yeah.
duplicating, we don't have a finance manager at treatment services. We've put in those resources to support them.
Great, thank you.
All right, Kim,
Yeah.
thank you so very much for that. And we'll move on to our health officer update. Dr. V, if you want to take it away.
Okay, I'll let you do it. I'm not advancing it.
Is arrow forward? Maybe.
Thank you.
It's not working.
I don't know why.
Do you have to use it? The keyboard is not working.
Where's our? Did it go to sleep?
Technical
There we go.
difficulties.
No, it's not. It was for a moment.
Thanks.
Hey, am I gonna have to use that?
There you go. Yes.
Oh.
Just right click.
Okay, well, good afternoon, everyone. Let me turn the microphone this way because I'm gonna have to click on the screen when I move forward. So today I have an update on a few issues that we've been tracking in the community for the last couple of months. I'll give you a quick update on what we know thus far from the measles outbreak in Texas, New Mexico, and Canada, and then tee up the conversation about the quality of life survey for 2025, which is going to be launched in March. So we'll talk about that briefly. And we have a former colleague back there, retired physician, and a future colleague over here, nursing student. So I did say that I will ask all the difficult questions to our nursing student. I'm just kidding. Okay, so, let's start with pertussis. And I know we've talked about pertussis before, but as you know, it's still with us. If you look at the numbers for 2025, we already have 442 cases in the state and a whole bunch of cases in the community. And unfortunately, as you know, we did have a fatality that we announced or released last month or so. So that's why I keep emphasizing the need for awareness, and thank you to all of our providers out there. I think there's a lot of testing happening. We've gotten a lot of requests for post-exposure prophylaxis, so that's great. That means that providers are active, but we still have a lot of, particularly kids with pertussis or whooping cough. And this thing doesn't like me very much. Whew, okay. So this is the comparison, the blue being 2024 as we were coming down. And you can tell that we started 2025 with this a little bit of an upswing that is coming down. Not uncommon for respiratory illnesses. We're not at the end of the winter, but there's always a little bit of an increase as we get closer to the end of the year when we're all getting cold and getting together. And that did happen. And you saw that when we look at the age ranges that were impacted, a lot of adolescents, but also a lot of infants. That is what we have thus far in 2025. This is by county at this point in time, as you can tell. We kind of have the highest number of cases, and that's not, we knew that going into 2025, which is the reason why we keep emphasizing the need for awareness and intervention, if at all possible, particularly infants, because infants don't present the same way. If you have an infant that coughs and then all of a sudden has apnea, stops breathing, you may want to think about that. Make sure your pediatrician is aware of that, because we do see that in infants under the age of 12 months, which is not what we see in older children. So these are the age groups, and as you can tell, we did have a significant number, again, in the younger adults, youth and young adults that move around a lot, and a whole bunch of the cases in children under the age of 4, which is where you expect to see many of this. Now, the reason why I share this with you is because if you have a household and there's an infant, and there's 3 adolescents in the house and a whole bunch of other people, we have to make sure that we are also taking care of those that are around that are at risk for exposure, because we do have post-exposure prophylaxis that can be instituted. And it is very important that kids get their vaccines at the appropriate times. We're seeing partially immunized kids, and that basically means they may have gotten first dose but not the second, and so on and so forth. So again, a reminder, it's beginning of the year is a good time to remind everybody, make sure that all of the immunizations are up to speed, regardless of your age, but particularly for children. This is, if you compare the end of last year to this year, you can tell that we did have this significant spike in the latter part of the year. We went up, we went down. We're still trailing up and down. We do believe that this is going to continue cycling up and down, probably for several weeks, if not a couple of months. And unfortunately, that means we will see more cases. The downside of that is, as you know, some of these cases can be severe enough to cause hospitalization. And as unfortunately as we talked about, there was already a mortality of a child under the age of 5. We don't generate a lot of the details because protecting the confidentiality of children and family. We don't want the family to relieve the issue. That's why the press release was somewhat scarce on details, and that's very intentional, just in case anybody had that question. So this is what we've seen in Spokane County specifically, tracks and trends with distribution we see in the rest of the state and other parts of the country, although we do have, as I mentioned, higher numbers. And these numbers will cycle in and out a little bit. I think as we all go back to school and et cetera, you start to see a little bit more in those age groups. And as we all go back home and are done in school, then we see a lot more of the infants and others. And we have had some of our later youth individuals, translation, that other people call that seniors. I call them later youth, so don't forget that both extremes of age at high risk for more severe disease, not just kiddos under the age of 12 months. So our later youth individuals need to be mindful of that. And this is what I showed you the last time. And I wanted to point out, because there's always some good news, I always try to find the silver lining on everything we do. And if you look at this blue line over here, or infants, we're really spiking up. Like that, as we predicted, was going up because of the seasonality that we see. And the good news is if you look at, if you look at as we trend into February, that's getting a little bit more control, which is good. So I would like to attribute to that, to the work of everybody, et cetera, et cetera, et cetera. So that's a great thing. Let's keep it that way. And I would like all of those lines to go down as much as possible. And they will. But I much rather they go down without any more hospitalizations and or severe disease. So that's where we're at with pertussis. We probably will be talking about pertussis for the next couple months. And moving on to the next area that we highlighted at the end of last year in Shigella, because we were seeing a few cases. We're still seeing a scattering of cases. We are not seeing the big numbers that we saw in previous years, and I'll show you a graph that has a bar graph 23, 24 into 2025. Remember that we had this significant outbreak in 2023 heading into 2024, which caused a really large number of cases in the community and a whole bunch of other complications. We still have some in 2025, and usually the question that I get is that in one specific population or segment of the population. And actually, the reality of the matter is, if you look at this distribution of where do the cases come from, it's a little bit of everything. It's not just in one segment. If you think about 2023 and into 2024, we did see a significant number in the homeless population, but that's not necessarily what we're seeing now. Of course, there are some that are homeless or in a shelter, but we're also seeing cases at home, and we have a long list of other area facilities where transmission has occurred. The most important thing here is we want to keep this control. Shigella is one of those things that if you let it take over, it will, and it will do so very quickly. So hand washing, good hygiene, make sure whatever you're going to put in your mouth, make sure you've washed your hands. And the reason why I say that is because it's not just food. It could be personal items, it could be smoking supplies, it could be all kinds of things. So let's make sure that we're following good hygiene. I do want to highlight, we've been working, during COVID, we started this group, which is our shelter and homeless providers, which we have continued. We meet every other Monday. And we talk about all kinds of things. It's more of a communication, like what's going on in your world. This is what we know, and our team goes and provides education on various topics, including precautions. And I think that group is doing a great job. So I just wanted to call them out, because I do know that those environments where you have this congregate living, lots of people coming and going, can be quite complicated. And those folks are doing a great job in trying to keep all of these things down. So we do want to give them some credit, and credit to the team that spends a lot of time with them too. So I think, again, those are good things that we need to be aware of, even though things are still happening. Now, I want to highlight our dashboard. I hope everybody has had the opportunity to go and take a look at it. It's actually very well done. Team put that together, and is a skill that we're developing a lot more. I think visible information to the community that easily understandable goes a long way in helping all of us understand better what's happening in the community. And that's the theory behind these dashboards. And you gotta click the right one or the left one. Figure that out. So this is as of basically yesterday. I just took a quick snapshot of it. And remember last time we talked about this really high peak of flu. We're doing better, but we're not out of the woods. If you look at the threshold, we're way up above the threshold. And if you saw the paper today, there was an article about the rest of the state having a significant impact because of the flu in emergency rooms and hospital beds and so on and so forth. I did talk to our healthcare providers last week and the week before. Very busy, lots of work, holding their own, lots of ED visits. Reminder here, not everything needs a visit to the emergency room. There are a lot of things that you can triage with your provider. We'll have messaging with our providers. There's also really good urgent centers in the community that are very good at taking care of things that don't require emergency room. Let's leave the emergency room for those that actually need it. And I think the highlights over here will be COVID-19 is there, but we have not seen, thankfully, the significant impact that we saw in the years past. The flu said, I'm back and I'm here to stay, which is what the flu typically does at this time of the year. And RSV, we've had smattering of cases going up and down. We're not steady, we just go up and down a little bit, but good news is we have not seen a significant increase as we saw if you look at the previous year over here. So let's try to keep it that way. Now, we do have now therapeutic interventions for most age groups with RSV, which we didn't have a couple of years ago. So that's always a good thing. We learn new things, and we have new tools to deal with that. Now we can cover every age group, including later youth and seniors. Okay, the right one.
Dr. V,
Yes, sir.
question for you on
Where?
the
Oh, sorry.
influenza. I mean, I assume this is based solely on the tests that have actually been given, but there's probably a lot of cases where it's just clear that they have flu and the doctor tells them go home and rest. Do we account for that at all, or is this purely just where we've tested and we know for a fact it's flu?
Yeah, these are the ones that, and what I'm showing, the reason why I showed this one is this shows you the percentage of ED visits with diagnosed respiratory illness. So these were diagnosed. We know they had the flu. But I also know anecdotally, because I hear it socially too, like, oh yeah, I think I had the flu. You probably did, but was never tested. Or I went to the doctor and they thought it was the flu, and I moved on and I got A, B, or C, and that was it. So there's no way to really account for those. But one of the reasons why I always talk to our providers is to also get the feel for what they're seeing. Because if they're telling me I'm getting overwhelmed, and then that's a little bit more worrisome. But right now, I think we're seeing those that are sicker are making it to the emergency room, and they're being appropriately diagnosed, and the appropriate intervention is happening. I also know the urgent centers are seeing lots of people, but there's no way to account for all of those that don't have a final diagnosis.
When I ask, because just using my household as an example, we all got it really bad, but we only knew it was flu A because we ended up taking our kiddo to
Yep.
urgent care, and he was, given the test, and so pretty good, idea that we all had flu A. So it just kind of anecdotal, but that it's broader than perhaps what the numbers show.
Yeah, and actually that's a very good point, because if we go off the diagnose and just go on what we hear, because I hear that story a lot, we got it, we took the kid to a pediatrician, kid got tested, and we didn't go to the doctor, so we probably did have it. So I do believe that if you remember that rise that we saw, maybe we saw a lot of the sicker patients in the emergency room, but under there's a curve of people that never made it to the emergency room or the urgent center or even the doctor that also had the flu. So the moral of the story is still here in full force. And if you read the article in the paper today, we're not alone. The whole state is seeing the same. So don't forget that you can still get your flu shot. I always tell people get it 2 weeks before Halloween. Then you can go trick-or-treating, but most people don't. Not everybody follows that. I try to follow that. But it's still here. It's still a concern if you have people at higher risk, like very young children, people in the other age range, or those that have any pre-existing conditions, any symptoms, please do go and get tested. Please go and get diagnosed so we know what we're dealing with, because it could be something else. And that way you can also prevent that from spreading in the household. Great point. Any other questions? Yes, sir.
On the graph, I see it's labeled the epidemic threshold, the dotted line. How is that calculated, and really what does that mean? I mean, whether you're above it or below it, is care delivered differently? Is something triggered if it
Sure.
goes above that line, or what does that mean, I guess?
Good question. So actually, if you were to go to below this, I can't move it because this is not the actual website, but if we were to go below that, there's an area that says recommendations for healthcare providers, and that's where the epidemic threshold, which is basically calculated on the basis of what we typically see, where do we start to see the bigger impact of the community, that has some recommendations for healthcare providers that could include everything from higher precaution levels to what some of our healthcare facilities did in December and some in January, which is they started to do masking in clinical and care delivery areas because of that. So there's a whole explanation there. I'm glad you asked that, because if you go on the website, you will see a lot more information on what do those numbers mean and how to use them as a healthcare provider, as a community member. Okay. So as long as we're way up there, lots of flu. That's something to be mindful of. Great question. Any other questions? So with that, I'm going to move on to something that we are tracking. I'm sure you've heard in the news about the outbreak in parts of the U.S., specifically Texas and New Mexico. and 2 of the Canadian provinces. So this is actually straight from the Texas Department of Health. And at this point, that was actually, as of yesterday, they had 124 cases identified since beginning of January. And 18 of those were severe enough to require hospitalization. We tend to think of measles, you get this rash, and but you can get a lot more than that. And it can be severe in some individuals. We do have the vaccination status of some, not all. And I think the biggest point here is we're tracking that because we all travel, like we were just off somewhere else. And so I'm going to show you where the potential exposures occur in the event that anybody was traveling either in Texas, New Mexico, or one of the Canadian provinces. But this is something that we're following just to make sure that we're aware of the issue and track it in the event that we were to have any patients in the area that had symptoms that could be suggestive of. So our healthcare providers are aware of it, and they will be very alert for any either traveling individuals and or signs or symptoms that could mean measles. This is where according to the Texas Department of Health, where the potential exposures occur based on when the individuals that moved through those areas that were at that point not symptomatic, but then were tested after that. And as you can tell, there's a whole bunch of places where people go, like the Ripley's Museum, right? And if you've been to Ripley's Museum, there's usually lots of people, very confined spaces, a lot of fun, but it's also lots of that. So this is not, they went to the clinic. They're folks that were out and about, and this is how these things happen. So that's why it's important to have that. And actually, I happen to know some of those places because I lived in Texas for a few years. I have not been there since then, but or recently. But just if there's anybody in the public that has been around there, including the University of Texas at San Antonio main campus, beautiful campus, just be aware of that and make sure that you're tracking yourself for the next 10, 14 days or so, just to make sure that we know if you develop any symptoms. We also know that there have been some cases across the border in New Mexico, and this is as of 2 days ago. They had about 9 cases. Not sure if there's a relationship between the two, but if you look at the geography, they're not far from each other. And if you have border towns, border counties, movement back and forth is not an uncommon thing to happen. Now, I can't say that yet, but just thinking that there may be some connectivity there. So we'll keep tracking this, and I don't have as much detail of the New Mexico cases, but I do have a little bit more detail of the Canadian cases, in case anybody was there. So I'm going to show you that next.
Dr. V?
Yes.
Just real quick, on your first slide, it said there were 5 individuals who were vaccinated that got it. And I'm wondering, do we happen to know, were they immunocompromised? Does the MMR vaccine wear off over time? Just curious on that.
So remember, there's recommendations for life for MMR. There's different age stages. I don't have the details on the patients. Don't know their clinical status. Don't know if they're originally from Texas, or we don't know much about it other than numbers. And the Texas Department of Health has not released that information either.
It's concerning to see that
their website.
Vaccinated individuals are catching this.
Well, remember that vaccines are never 100%. There's always some gap and some effectiveness, so there's always that leeway. Plus, a lot of these vaccines, where we're talking about pertussis, we're talking about, there's some schedules that are recommended for various age groups and various clinical conditions. But unfortunately, I don't know any of the clinical history, so I don't want to speculate because I don't know their issues there. But good point. Remember that vaccines are really, really good, but they're never 100%. We don't have any vaccine that's 100%. Okay. So these are our friends from Canada. Quick geography lesson is most of the cases are over here, Ontario and Quebec. If you remember your geography, the Ontario province shares about a 445-mile border with the state of New York. Niagara Falls is on this side, Niagara on the Lake is on that side. If you go up the hill, beautiful place. There's a lot of traffic between New York and Ontario and Quebec, but a lot more on Ontario. And if you look, Washington will be, where's my thingy? Over here, we're closer to this end. There's three main connectors, the Ontario province, Windsor, which is where Detroit is in the middle of the country, and then British Columbia, which is where we are. And we share a 220-something mile border with British Columbia. It's one of the reasons why we're always tracking what's happening elsewhere. Because bugs, no borders, they don't really care, they move around as necessary. So we do have a number of cases that have been identified. And I do have a little bit more detail on the cases in Canada, not enough to answer the question that you have, although we're getting some genotypes and so on and so forth. So I'll give us a little bit more so we can make the connection. Is this the same as over here? But more to come on that. We'll keep tracking this. And again, the main issue is, remember that this travel, and this is very easy travel. A lot of people going back and forth to Canada. That happens all the time. So let's be aware of that. And if you're going to travel, make sure you talk to your provider about any precautions that you may want to take. And we'll update you on the next board, at the next board meeting if we know. I'm assuming we'll know more about it. And hopefully I'm not going to tell you that it's in other places.
Commissioner Waldron has a question, and then we'll go to Patricia.
I was just going to ask Dr. V, where do you get this data? Does it come directly from Canada to the US, or is it through the CDC?
Oh, yeah. No, I actually get this, I can get it directly from the province, the Canadian provinces, and the other data I got directly from the Texas Department of Health. So that data is available through the various jurisdictional sources.
Patricia?
Good question.
Is the unvaccinated status so high because of the age group of the people who are contracting?
Well, we could certainly speculate that, but I don't know that for a fact. And actually, I should have gone and looked back at the Canadian recommendations for immunizations, which I didn't. But that would be interesting to do an overlay on what the Quebec and Ontario province versus like us, for example.
If they don't require it until you're 6 years old or something, then that might explain why it's so high. But.
Yeah, good point. I will look into that because I did not. I was mainly tracking where it's at as opposed to how. But good point. That would be an interesting exercise to do an overlay of the two, just see what the requirements are. Because remember requirements, and I was having this conversation outside, even within the country, we do have some different requirements for like school immunizations, et cetera. So there's always some variation. Great point. Community collaborations, it is time for the quality of life survey, and as Kim mentioned, actually, this is $125,000+ and a lot of it comes from our community partners, Providence Multi-Care. I do know that our team applied for a matching grant from the Health Sciences and Services Authority, which was obtained $40-something thousand. So all of this is paid basically with external funding that comes to us. And the quality of life survey, plop. We'll roll that out in March. This will be the 10th year anniversary of the quality of life survey. It started in 2015. We'll get everything back by the fall, give or take. And this year, we've actually made sure that we have multiple languages available. And I know the team is doing some very targeted, very specific outreach to make sure that we're indeed getting broad population. There's not just isolated in some areas. And the quality of life survey is used by any organizations. I just mentioned HSSA, for example, with full disclosure. I'm the chair of their board, but it has nothing to do with this conversation. It's just full disclosure. We have access to care grants, and we use the quality of life data as well as a community health needs assessment to kind of guide what are the specific needs in the community that we should be looking to support. So it gives us a little bit of direction. I know other organizations, other nonprofits use it too, to target their funding and or support. And it gives us very specific information to us from a public health perspective on one of the key issues in the community that we need to focus our attention more. So it's really good for all. And the team upstairs does a great job in dissecting. Dissecting is a very medical word. It's analyzing this data. They don't say dissecting. I say dissecting. So more to come on that. I'm sure when this is done, we'll have the team come and do a presentation for the board, so you get the results. Okay.
Dr. V, do you know, so when it says Northeast Spokane neighborhoods, are we talking the formal City of Spokane Northeast neighborhoods, or is it broader than just city neighborhoods?
It's actually broader than city neighborhoods.
Okay.
But the reason why there's some neighborhood areas that we're looking at is because based on previous results, we know that there were gaps that were perhaps not clearly identified. One of them, for example, was some of the languages.
Well, and on that, I guess I would wonder too, why not Chinese and Vietnamese being included in that? Those are, in the city, we've identified those as major languages, so.
True. Some of that has to do with population that are more bilingual. But we always find out that there's another segment of the community that we need to address better. Maybe that will come up on this one. And I think little by little is like everything else. The more you do it, the better you get at it. So more to come on that. But I'll pass that along because I know that we look at a large number of languages, and this was decided based on the actual impact and the ability of the individuals to understand the information. So that's where like being bilingual comes in.
Sure.
Like I was born in Spain, but I speak English, so I wouldn't be in that category, but not everybody's that. Good question. More to come on this in the fall.
Okay.
So with that, if this allows me, I will stop and see if there are any further questions, and if not, I'll pass along to Danielle, because I know that Lola, that has do you have a legislative update?
And just an FYI, we've only got about 17 minutes of our official time. Some of us can probably stay longer, but just an FYI.
Yep, no, we timed it, so we'll be done. You're next, thank you. That's mine.
I think I can move through this pretty quickly. You know, we started out with nearly 2,000 bills being presented this year. We are moving really fast through here. All I'm highlighting today are those WSOLFO partnership high priority bills that we've been talking about, and only those who've had activity since the end of January. So we'll just lead through this really quickly and probably not hang on any one too long, but just know that the February 28th fiscal committee cutoff is coming up. And so we're looking at House Bill 1380 for utilization of public property. That's an appropriations. Senate Bill 1238, Rare Disease Advisory Council, referred again to appropriations. 1531, communicable diseases, referring to rules. And then the hepatitis B and C screening, referred to healthcare and wellness. Did I get that? Nope. You gotta be right on that button, don't you? Okay. So under community well-being, we've got, and resilience, we've got House Bill 1520, that's the pharmacist scope of practice. I don't know let's see where I've got that, pharmacist scope. And then the 1186 which is medication dispensing. That's to going to the second reading. 5019 Senate Bill pre-packed medication distribution. That also moved to second reading on February 7th. I haven't seen an update since then, so that could be moving off. And then Senate Bill 5335, rural nursing education, which is something we were looking at even last year. that's gone to Ways and Means. And then Senate Bill 5372, the Medicaid Access Program, went to, looks like Health on the 20th, so just recently. Then under Substance Abuse Prevention, Treatment, and Recovery, we still have a live Senate Bill 5201. That has gone to LNC. What have I got there? Labor and Commerce, with no action taken since February 21st. And then Senate Bill 5229, which is a civil commitment for the revival by opioid overdose reversal medication. That's also gone to Ways and Means. That has not moved since the 3rd of February.
Is 5201, is that sort of allowing like clinical type usage of those, or what?
Yes.
Okay.
Yeah. It's expanding that to actually support the use of it. In environmental public health, we've actually been really busy this year. We've got Senate Bill 5632 for those on-site sewage systems. I know I talked a little bit about this last year. We've got House Bill 1154 for solid waste. And then Senate Bill 1497 for waste materials. Also some movement on that just as early as, I think, Monday. We are looking at Senate Bill 5033 with a lot of interest on the PFAS. The last movement for that was to Ways and Means on February 26th. And then Senate Bill 1303 for environmental justice went to the House Committee, it looks like, on 2/19. I have rolled through this really quickly, so if there's questions, please let me know.
Yeah, I just have a question. Assuming that those bills that we're watching, those are all bills that we would support them moving forward, is that my assumption? Is that a correct assumption?
Well, that is a correct assumption. So when I'm doing the presentations, I'm really just focusing on those bills that would be in the purview of the district and or directly in a positive way affect our community. And so we also partner with WSOLFO, and we get their high priority bills, and we kind of look at our own internally to see what we would be looking at. And so what's presented to the board each time I do this presentation is the bills that we're focusing on, and then those that are still moving through. So this list gets smaller each year, from the beginning of the legislative session till the end. Yeah.
So if these are bills we're theoretically in support of, where does 1303 come in relative to the legislative agenda that we approved?
Hang on, I'm going to find it and get some detail. 1303.
I'm just not sure what environmental justice statements have to do with our ledge agenda.
No, that actually was not for the purview of the district. That was the purview of WSOLFO. That was a shared high point for WSOLFO.
Gotcha.
So again, some of these are specifically ours that we've pulled in that were not in WSOLFO's purview, and some of them were primarily in WSOLFO's purview on behalf of LHJs across the state. Is that helpful? Any other questions?
There was another one you had up there, 1380, which I know has kind of been a hot button bill about the homeless encampments. I think that was the first one on your first slide.
Mm-hmm.
Is that one that WSOLFO was supporting, or is that one that the district is
That was
putting
one
their
that
support
the
behind?
district is supporting. Yeah, that's one specifically that the district is supporting. Just
To override local control on homeless
HB
encampments?
1380?
1380?
1380? No, I'm sorry. No, this is a WSOLFO.
Okay.
Yeah.
So WSOLFO supports.
Well, so
That's wild.
So when
Okay.
they say support, they're saying that there's high interest in what happens with the bill. So these are, they're saying medium and high interest, and this bill is going to impact us. We need to keep an eye on things.
So they
Not-
could, in theory, be opposed to the
They
bill.
could, in theory, be opposed. When they give that information to us, they're saying this is a high interest. So my list
Okay.
from them is a high interest, high to medium impact to our community.
Okay.
So, yes.
Oh.
Sorry, that, I could have stated that better. Yes.
For next month, could we just kind of maybe add a little indicator as to, you know, who's watching it and if there is an official support or opposed?
We absolutely could, yeah.
That'd be great.
And actually, it'll be a smaller list by then, so that would be fairly simple. Any other questions before
I had a question. I just was looking for the one that was about increasing the number of Native Americans on health boards, Board of Health. And I don't know what the number is, but if you can look into that a little bit. I think Natasha Hill is sponsoring that one.
1946.
1946.
Okay.
I'm wondering if, what's happening with that?
It's in
Do you know? It is.
Yeah. Yeah, it passed out of committee, and it is in rules.
Thank you.
Any other questions?
Okay, seeing none, we should move on to our presentation. Can turn this over to Danielle.
So while Madison is doing this, I just want to thank the board for approving our ability to partner with Gallinger. I'm really excited to introduce you to Derek, and he will be presenting on our compensation and benefits review for this year. He's going to go over the project, the approach, and the timeline. Okay, Eric, I am going to go ahead and turn this over to you, and I will just navigate the slides.
Thank you. It's a pleasure. Thank you for taking the time this afternoon. I'll move through quickly but appropriately, recognizing that we're at the end of your agenda here. My name is Eric Smetana. I serve as the Managing Director and Practice Leader for Gallagher's Public Sector and Higher Education Practice. We can go to the next slide there, Danielle. And here are the things we're going to cover today. We're going to talk a little bit about Gallagher. I'll keep that brief. We'll talk about the project goals and sort of the process, the work plan, the timeline, the next steps, et cetera, as we work our way through that, sort of where we're at and how we're moving forward overall with this project engagement. We can go to the next slide. And a little bit about our team, our particular practice. We're coming up on about 40 years of serving public organizations across the country. We're a nationwide practice that specializes within the public space. We work with health organizations across the country, as far west as Hawaii, up and down the eastern seaboard and all points in between. And we have specific experience with Washington organizations in the Pacific Northwest. I won't make you go through the items at the bottom, but those are the array of services that we provide overall in addition to compensation and classification. Go to the next slide. And so to start talking a little bit sort of about how the project works and sort of the inner mechanics of it, we have a dedicated project team working with the Spokane Regional Health District team. That includes myself serving as the project advisor and project director, Dr. Derek Smith, who is serving as the project manager and senior consultant, and a whole project team that's supporting this in the background, including consultants and associate consultants, in order to make sure that we're supporting your needs, but also your decision making as you get this information and move forward as an organization. Part of what that includes is regular status meetings. We're meeting with your team every other week, sometimes more frequently with some sort of 4 to 6 week meetings with the leadership team and myself. We're having regular engagement across the organization, and we're really focused around communications in general. We recognize that a study of this nature, for all the best data in the world, it's really important that the stakeholders understand what is happening, how it's happening, and the process that goes behind it in order to ensure the success of the engagement overall. We can go to the next slide. And so let's talk about the project in a little bit sort of detail itself. One of the important things we like to talk about anytime we do this kind of work is what the study is, and sometimes more importantly, what the study is not. And I'll start over on the right-hand side of that table. These kind of engagements are not a study that are a strategy to look to reduce or increase pay. It's to understand what does the market bear, what is it telling us, helping us understand that thoroughly to support decision making. It's not a staffing needs study. It's not an organizational structure study. And it's not a strategy or study designed to cut costs specifically. And it's not a strategy designed to eliminate positions. What it really is designed to do is to help us help you ensure that the roles, the levels of roles are aligned appropriately internally, but also to the market, that you have a process and approach that you can continue to administer, sustain, and maintain independently of us on a going forward basis, that you have guidelines, policies, procedures that wrap around that ensure that the systems are up to date, but also equitable, but that allows you to be competitively placed to the market in a way that makes sense for the district specifically. We can go to the next slide. And so I'm not going to go through each of the little details here. There's a lot of text on this screen. But the way that we break up an engagement like this is we start with administration. That begins with what we call a data discovery discussion, in which our team sat down with your team and worked our way through what are the nuances, what are the complexities, what are the particular challenges facing the district. From that, we move into a cadence of regular status meetings, conversations in which we're educating your team in terms of what the project is, how it's going to work, what those deliverables will look like. And we first move into a phase of classification. And so we're looking at the structure of titles, the job families, the title series, et cetera. We're looking at FLSA compliance and the regulatory pieces with that. As we move our way through classification, that gives us clarity around not just what are the titles that are being leveraged, but what are the roles doing, so that we can match those positions out to the market during the compensation phase of the study, in which we're doing a custom survey, but we're also using a published survey library that we have here at Gallagher, which is one of the largest published survey libraries of any consulting firm in the country. And we take those bits of information, the custom survey, the published survey, blending that information together and presenting that back as we get to the end of the project in a tool that we call a benchmark summary, that again is designed so you can maintain and sustain this internally as an organization. And then we move into final reports, recommendations, and presentations, which we walk through our recommendations and our findings overall. We can go to the next slide. So overall, the full project, sort of from start to finish, is approximately 6 months. On average, projects of this nature take that 5 to 7 month window. We look to move as expeditiously and efficiently as possible, but we recognize that the full project may take through that June window. But we anticipate having preliminary information much sooner than that, working with the district team to walk through that data overall as we get the results in from the custom survey, as well as the published survey analysis. We'll begin to share that information so that we can make sure that that information isn't something that's just being seen at the end. It's something that we can have thoughtful conversations around to make sure that we're on point accurate as we work our way through that process. Go to the next slide. So in order to do that and have that accurate data, as we work our way through that classification process, we go through a benchmark job selection process. And so what that means essentially is we want to ensure that we have positions that are representative of the entire employee population within the district. And so that means different levels, different job families and functions, those roles where you have a large number of incumbents, but also those roles where you say, gosh, we have a really difficult time recruiting and retaining individuals in these particular roles, as well as those jobs we're going to find out in the market data itself. And so it's a comprehensive look through that we're wanting to ensure that we're representing in the end results of the study every role across the district. We can go to the next slide. And then from there, once we understand that, we start to talk about sort of the nuts and bolts of it, if you will. The first part of that is talking about a compensation philosophy and understanding sort of where are you at today, where do you want to be relative to the market? A compensation philosophy serves a whole variety of things. It helps from a budget and planning perspective. It helps from a cultural and value statement perspective. It helps you to think about it as a recruitment and retention tool. But it's really a statement that talks about how do you approach the market when you think about your workforce? But it also allows you to think about where do you want to be positioned to the market? And as we continue into this engagement and information that you would see later on in the engagement, we talk about your position to the market, whether that's at the 50th percentile, the market median, or some other place. And we work to understand, do you wish to be market aware, market leading, some other point in between, and we work with you closely to ensure that you have a philosophy that represents where you are and where you want to be with that overall. You can go to the next slide. And here, this gets into the compensation philosophy a little bit more. As I said before, there's sort of 6 key points when we think about a compensation philosophy. First is that compensation decisions piece. How do we approach the market when we hire individuals or promote them? Again, it becomes a recruitment tool. It allows you to think about employee satisfaction, motivation, engagement. We know that that research suggests when individuals go to work somewhere and stay somewhere, that they're the 2 biggest pieces of why they do that, and these are both applicable very much to you. The first is affiliation. I want to work somewhere that I am excited and proud of the work that we're doing. That is the key driver. And number 2 is compensation. And so this allows you to think about that through that perspective, that you have the affiliation piece of who you are and what you do, and then the number 2 factor there being compensation. Again, it allows from a financial planning, budget compliance perspective. But as you think about overall sort of performance management, market alignment, et cetera, it ties back into that. And again, it becomes that cultural statement, allows you to thoroughly communicate your values. So it's not just a number, it's really sort of, it truly is a narrative that speaks about who are we and how do we want to accomplish this. Next slide, please. As we begin to collect data through the course of this study, what we're going to talk about is your position relative to the market and that market point. Within 5% above or below the 50th percentile of the market median is something we consider highly competitive. Within 10% continues to be competitive. Within that 11 to 15% window, maybe there's a misalignment. It doesn't necessarily mean that you're off target. It may mean that there are reasons and justifications for why we're seeing that across particular positions. It may be a particularly difficult recruitment market for certain roles, et cetera. But those are where we start to want to understand, why are we seeing these outliers or these anomalies? And anything over 15%, again, there could be reasons or justifications for it, but we'll have a conversation with the team to say, this is what we're seeing relative to the data, or this may help us to prioritize with you sort of those roles that have sort of prioritization as we think about how do we attack this overall. In addition to the custom surveys that we'll develop and facilitate from our published survey library, there are 4 key sources we use. That's WTW data, Willis Towers Watson, Mercer, and Comp Data. They're some of the largest survey houses in the country. Those all sit inside of our survey library. We also take ERI, or Economic Research Institute data, which allows us to apply factors and geographic differentials around cost of labor and cost of living to that data, so that we're really talking about dollar-to-dollar comparisons, whether that's from the custom survey data or from the published survey data. We can apply those differentials to ensure that we're really truly looking at the right data overall. Next slide, please. With that, as we talk about the custom survey, there are a handful of things that we're looking at there, and it's really thinking about your labor market. This ties into the custom survey, the published survey. We look at the types of organization, public versus private, the size of those organizations, and that, when we talk about size, that could be the number of FTE, that could be sort of the area they serve, that could be an operating expenses perspective. We have a sort of really thoughtful conversation around that. Obviously, geography plays a role in this. The kinds of services provided, and even if we're looking at similarly situated organizations, there may be services that vary. We want to make sure that's appropriate. There may be aspirational organizations that we want to get into, or organizations that you say we consistently gain talent from or lose talent to these employers, or other factors that you identify that you say are of importance. And so we use that to build out that custom survey and also look at that published survey data. You can go to the next slide. With that, digging into that a little bit further, from a published survey perspective, right now what we're anticipating from a published survey is looking at state of Washington from a geographic cut, regional, which is the west you see there in the yellow, and then we have national data that may be appropriate for certain roles, and we tie that back to the kinds of positions you have overall, recognizing that for some positions it's a very local market, in some positions it's more regional, in some positions it could potentially be national. We're looking, to make sure we understand the nuance between the for-profit versus not-for-profit, what's the right mix, if there's a mix at all, public versus private, et cetera. One of the things that we'll want to confirm as we go forward, obviously, is how we cut that data to make sure it's representative of how you want to be represented in the market. Once we start to have that information in, we start to go through some of our internal processes. We're reviewing those matches to both the custom survey as well as the published survey data. We begin to look at, again, not the titles, but really what are the roles doing. We're performing statistical analysis on that. We're identifying outliers. We're identifying anomalies. We're also applying data aging to that. Right now, we're anticipating aging that data to 9/125, but that's certainly a flexible number there overall. We want to align that with how you might want to deliver any pay actions that you do. And we use World at Work data, which is a compensation professional association, to help us and follow their formulation on data aging so it's compliant and best practice. And again, we'll be making those geographic adjustments to any of that data as appropriate, leveraging Economic Research Institute data to talk about the cost of labor across those differentials. You can go to the next slide. All right. I think we can move on to the next one. Oh, that was too fast. So question, the next steps is the next slide. So are there any questions I can answer about the project, the engagement that you might have?
Anything from anybody? Not seeing any hands. All right. Well, thank you so very much for that presentation.
Thank you. I appreciate the time this afternoon. Have a great day.
Absolutely. Okay, well, real quick, why don't we do a quick round robin here? Any board member updates to be had? Commissioner Kearns? Patricia?
No.
Okay, I think we've lost Dr. Plakowski-May. So Commissioner Waldriff, do you want to close us out with anything?
Oh, I just wanted to say that I had been talking to Patricia about if there's any way we can get these presentations in our board packet ahead of time, that would be great. I know sometimes people are preparing them within a few days, but then we could review them as board members and have questions, ready to go if we had them. So it's just a thought. So I'll talk to Dr. Thompson and Ann about that, whether that be possible for next month.
I think that'd be great. And I was actually just thinking, I wonder if it'd be possible for us to just kind of move this agency subsection up to its own after action items, just so we make sure that we're given the proper due diligence to these reports and they're not falling off at the very end. But we can talk about that in the exec session. So if there's nothing else for the good of the order, we will call this meeting adjourned at 2:38. Thanks, everybody.